esteemed delegates, and honorary guests gracing the dais. A very warm welcome to each and every one of you here at ISB Healthcare 4.0. I'm Dr. Shweta, radiologist at Krishna Institute of Medical Sciences and a member of the Advanced Management Healthcare Program 2024 cohort. Today, we embark on exploring a vital nexus between health financing and improved health outcomes. Joining us as a moderator for this session is Professor Sarang Dev. Professor Sarang not only serves as a Deputy Dean of Faculty and Research at the Indian School of Business, but also holds the esteemed position of Executive Director at the ISB Max Institute of Healthcare Management. With a wealth of experience and expertise, Professor Sarang leads an interdisciplinary team of faculty and researchers focusing on the profound impact of operational decisions on population-level health outcomes, spanning both public and private sectors. Please join me in extending a warm welcome to Professor Sarang Dev as he guides us through today's discussion on the health course. Continuing with our distinguished panel, we are honored to welcome Dr. Gurva Reddy, sir, Managing Director of KIMS Sunshine Hospitals. Dr. Gurva Reddy is a renowned visionary in orthopedics, celebrated for his compassionate approach to healthcare. With a remarkable record of nearly 2,000 joint replacements annually, he stands as one of the top joint replacement surgeons in India. Today, Dr. Gurva Reddy will enlighten us on leading with a vision to embrace the human side of healthcare in the field of orthopedics. Next, we are delighted to welcome Shri B.C. Patnaik, a member of the Life Insurance Regulatory and Development Authority of India. Shri Patnaik, sir, brings invaluable insight into regulating innovation in health insurance. Previously serving as a Managing Director of LIC since 2021 and as a Secretary General Counsel for Insurance in Mumbai. His expertise is unparalleled. Next, we are privileged to welcome Dr. Krishna Reddy, CEO of Access Health International. Dr. Reddy spearheads the overall development, management, and leadership of Access Health's activities across the Asian region. His dedication to driving the agenda for healthcare excellence is commendable. Last but definitely not the least, we are delighted to welcome Dr. Sandhya Venkateshwaran, Senior Fellow at the Center for Social and Economic Progress. Dr. Venkateshwaran is deeply engaged in a wide array of social sector issues, including health, gender, natural resources, and urban development. Despite joining us online, her invaluable insights promise to enrich our discussion profoundly. Please join me in extending a warm virtual welcome to Dr. Sandhya Venkateshwaran. Over to you, sir.
Good afternoon. Okay, I was just checking because when I said good morning, the energy level was slightly different. So I'm hoping it continues here. Some of you in the audience may have attended last year's event and may recall that we had a very lively discussion on value-based care. That was the opening panel. And one question that emerged out of that discussion was, would healthcare providers want to move towards value-based care as against volume-based care on their own? And if they did so, will that be financially beneficial for them? Okay, because as we heard in the previous panel, there's profit-making legitimate objective, and so will value-based care lead to better financial outcomes for them? And so then that led us to think about this topic, which is, do we also need changes in healthcare financing if we want to move towards better health outcomes? Okay, so that's really what today's panel is. How do financing of healthcare interact with provisioning of healthcare or delivery of healthcare and thereby outcomes? Now, Krishna pointed out to me, which is very appropriate, that we shouldn't think that the only way to drive outcomes is by changing financing. There are, moral frameworks by which we can improve outcomes, ethical frameworks. You can think about financiers and providers as partners. So it's not just pay for performance, it could be various other frameworks. Given the time that we have, we may not be able to cover all of these other drivers of outcomes and frameworks. We'll focus our attention on financing as a lever, acknowledging that there are other levers. And so if you have those questions, you can park them for later, surely. But let's start with basics. So the two panels that we had in the morning, it should be clear to many people that in India, primarily healthcare financing is mostly individuals who pay directly to healthcare providers, what we call as out-of-pocket expenditure, OOP. Many of us are aware of this. And there are perils of that model. We'll talk about them. But then also there's an alternative to paying out-of-pocket, which is insurance. Again, it's a two-step process, right? Insurance, I may pay out-of-pocket or with the help of an employer. But then who pays the healthcare provider is an institution and not an individual. And again, there may be benefits and pros and cons of that approach. And then we also talked a little bit about managed care, which is another form of financing plus provisioning. And then more and more terms will tumble out, okay? So there's capitation models and this and that, and hopefully we will cover some of these as the discussion goes along. But let's start with the simplest one, the quote-unquote crudest one, which is out-of-pocket expenditure. And I want to start with Sandhya because she's going to bring in a unique expertise here. Sometimes we think India is everything, right? India has out-of-pocket expenditure of a certain percentage, so that's it, what can we do? We are here. But I think it's useful to then benchmark India's experience with other countries. And so Sandhya, I think what would be good to hear from you is what's the global experience with out-of-pocket financing of healthcare, and what may be the reasons why it is not desirable? If you can lay out that framework, then we can start moving from there to something else.
Thanks, Sarang. Can you hear me?
Yes.
Okay, lovely. Thank you, Sarang. First, my apologies for joining virtually. I was all ready to join until yesterday evening, and then sudden change of plans had to happen, so my apologies. So yes, financing is a key lever. I agree with both you and Krishna that provisioning along with financing is key, combined together, but they are really connected in many ways, as has been discussed and will be discussed as the day proceeds. So, you asked me to talk about OOP. I want to just step back, if you'd allow me, for about 30 seconds to talk about something that everybody knows, but just to underline it. What are the typical ways that health financing is designed? What are the elements? So there is government funding, tax resources. There is funding, private funding, out of pocket. There is funding by employers, social health insurance, and then a little bit from here and there, donor funding, non-profit, etc., etc. The three main areas are tax funding, out of pocket, and employers. Again, the next sort of level of design is whether it's supply-based financing, demand-based financing. Supply is where typically when health is financed in terms of inputs. That is, financing is done for infrastructure, human resources, drugs, diagnostics, etc. Demand is typically insurance or other demand-side financing in the form of vouchers and cash transfers, etc. Where access to health services is incentivized through payments. So these are some of the elements of how financing is done. And when we were to step back and look at them, the way these function, none of them really incentivize quality, a focus on pricing, accountability, etc. And that's where the problem starts. But I'll come back to that. When we look at India, in India, if you were to look at the breakup of health financing across these, approximately 50% of current health expenditure is out of pocket. And I'm saying current health expenditure, not typically people look at THE and you'll wonder, no, this data that she's citing is all wrong. About 52% of current health expenditure is out of pocket. About 14 odd plus is insurance, variety of insurance, and 29% is government schemes, which are not merely schemes like National Health Mission, but also the money spent by the Ministry of Defense, Railways, etc. As you know, they have huge health programs for their employees. So you can see that it is quite fragmented, and even within government expenditure, there is fragmentation across. Before I get into that. So you can see that the bulk of the financing in India is out of pocket at 50 plus. That's one point I want to underline. Now, when we look at the tax financing, it is fragmented across ministries and within the health ministry. So, one is coming from the Ministry of Health, then there is Ministry of Defense, there's Ministry of Labor, there's Ministry of Railways. So there are multiple ministries that are actually providing tax resources for health finance. That's a second level of fragmentation. When we look at a third layer, within the Ministry of Health, there is financing that's happening through government schemes like NHM, and there are state schemes. Then there is financing that happens through CGHS, which is for government employees. Then there is financing from the Ministry of Health that goes into NHA, that's the PMJ insurance. So there is point I'm trying to make is there is horizontal fragmentation and vertical fragmentation. So that's in a nutshell, really the landscape of financing, health financing in India, the bulk of which is out of pocket. Now, out of pocket is high. Why is it high? And I'll come to your question, Sarang, on why is it a problem or is it a problem? There are two prime reasons why out of pocket would be high anywhere. One is the quantum of money that the government is putting in, and the second is how it's designed. Now, when we look at the quantum of money that the government is putting in, I think it's very well known to everybody that it's very low. India is amongst the lowest in terms of public allocation towards health, 1.3, 1.4. For years, it's hovered over 1% of GDP from 0.91, 1.2, 1.3. It's amongst the lowest in the world. When we look at some of the other countries, Thailand, which is, in many ways seen as a poster child for health system, it's 2.7% of GDP. Turkey is 3.6%. Indonesia is 1.6%. So while Indonesia, as we'll see later, is not that far away from India in terms of the tax allocations, but they're still doing better. That brings me to the second point. What is, apart from the quantum of money that the government puts in, what else is important from the point of view of out-of-pocket expenditure? And that is how the money is designed. And I talked about fragmentation. So when the money is fragmented, it basically doesn't allow for the creation of pools that enable the payer or the purchaser, however it may be designed, negotiating prices from providers and negotiating quality and better accountability. And all of these combine to result in a situation where the ultimate citizen, all of you and me, let's say, end up paying much more. And that's really these two issues combined, the quantum of money paid by the government and how the money is designed are what are contributing to high OOPs. This is why where, Indonesia, even though government health expenditure is 1.6%, but they have brought their pools together, which has resulted in better out-of-pocket expenditure. So let's look at what is happening to out-of-pocket expenditures in other countries. India, we said about 52% of CHE. Thailand is 9% of CHE. Turkey is 16% of THE. And Indonesia is 32% of CHE. So even one may argue 32 is not that great, but considerably lower than where India stands. And one can cite many other country examples. The bulk of them do better than India. What is the problem with out-of-pocket expenditure? When we spend money out of our pocket and we pay for it at the point of service, because of information asymmetries, we are neither able to negotiate prices nor quality and accountability, which basically means that as a citizen, accessing health services, I'm in no position to know whether what is being asked of me in terms of procedures, in terms of diagnosis, in terms of the medicines taken, whether they're correct, not correct, whether those are needed. I have no control over that. I'm in no position to actually ask for efficiencies into the system. And that is why the worst way of actually paying for health services is through out-of-pocket at the point of services. What can be done? Countries, when we look across different countries, we see that countries that have undergone reforms where they have tried to address some of the fragmentation that I've talked about have actually been quite successful in curbing their out-of-pocket expenditure, in addition to other benefits that they've faced. Turkey had 5 risk pools, insurance pools, which when they went through reforms, a host of countries went through reforms in the early 2000s. And they consolidated their 5 risk pools into one. Thailand and China aggregated 4 risk pools into 3. Indonesia aggregated 3 into 1. So the point I'm trying to make is that the issue of fragmentation is something that many, many countries address. What that did was that it brought a large pot of money together, enabling the purchaser to negotiate with providers for better prices and better quality, something that is very difficult to do when we are dealing with small pools, which is the situation in India right now. The other part that these countries did was also introduce strategic purchasing. I'm sure it will come up later in this panel, which basically focused strongly on who is health being purchased for, who is it being purchased from, what exactly is being purchased. So these are some of the elements in strategic purchasing. So the combination of aggregating pools and combining strategic purchasing and other reform elements as well led to considerable reduction of out-of-pocket expenditure in many of the countries that actually engage with reforms. So let me stop here, since you said introductory remarks. So the key takeaway is India has high OOP. India is where some of these other countries were. They undertook reforms. Of course, they invested much more in terms of tax resources. But whatever the quantum of investment they may be, it was designed or architected differently from the way India is doing currently, and that helped these countries to reduce their out-of-pocket expenditure. Let me pause here.
Thank you, Sandhya. There's so much in this response. What I took away, maybe for the audience, just to summarize, we often bicker about, the government is spending very little on healthcare, or the budget that came out, X% of the budget is for healthcare. Sandhya is saying that's just a start. Given how much is being spent, in which way, shape or form is it being spent is also important, because government is not a single entity. For someone outside, you may say government is spending, but within government there are different ministries, different pools. So there is fragmentation there itself, and other countries like Indonesia may have shown that for the same amount you spend, if you can consolidate, you get some benefit. I think the out-of-pocket expenditure, to me, the first thing that comes to mind is catastrophic expenditure and people falling below poverty line. We hear about it quite a lot, and I think it's the first order effect. But the second order effect is, maybe not second order, but second effect is you're not able to ask for better services, better quality, better price. And so those are the reasons why you may want to move away from out-of-pocket expenditure. But where to move away is also important. It's not just you eliminate out-of-pocket expenditure or reduce and make government spend money, because they could also spend in a fragmented manner. So the second level of discussion that needs to be had. One such approach, and I'll come to Krishna now to you, one such approach that is being tried out, one could argue, is people who are below or close to below poverty line already. Some of them were spending money on their own when they went to hospitals. And then we had these various state insurance schemes and now PMJY, which is covering them, right? So if I take Sandhya's argument, one could say, okay, so now you've got some economies of scale. What are the opportunities in that framework, in the current PMJY-like framework, to get the benefits that we think we can get from scale? How can we drive towards better quality, better pricing, reduce unnecessary care, so on and so forth? And I'm asking this because you've done work in multiple states, closely working with the state health authorities who implement that scheme. So if you can share some experiences, whatever has been achieved, but also what can be done going forward and is still undone, or let's say unfinished agenda.
Yeah, thanks, Sarah. Since most of them are providers, if I'm a patient, I'm paying out of my pocket. The only way I assure my value is I dump a poor quality consultant, I dump a poor quality lab, or so I change. So I trust, that's the competition, whether the patient is getting a value, but it's only a chance for them. It's a 50-50 chance that they are really getting the right. So when the purchaser becomes large, as a PMJ or a private health insurance or CGHS, that's where they have the negotiating power with reference to the providers. Most of you providers, you only look at the benefit package, pre-authorization, benefit package, and disallowances. The most of the focus, both the insurers as well as the providers, is only on the claims processing. But as the insurer, I'm accountable to the beneficiaries, the policy holders, in the case of private health insurance, and the beneficiaries in the case of public health insurance, whether it's PMJ or Arogeshri. But that awareness was not there in the policymakers, that they are accountable to assure quality to the beneficiaries. It's not just the financial cover. If you look at the universal health coverage definition, it's not just the financial cover to prevent hardships. Financial cover to access sufficient quality health care in an equitable fashion and a dignitable fashion. So these three elements are conveniently ignored by both the providers as well as the insurers. So that's where I think the first step in PMJ when we are associated with UP government SACHIs is to create that awareness among the SACHI administration itself that you have to look for quality. What your PMJ beneficiaries are actually getting in terms of the quality. Right? I mean, we had a CGHS example of driving quality by incentive, the carrot and stick method. I mean. So as a purchaser, CGHS, when it gives 20% extra increment if you have NABH accreditation. So that is one way of influencing a provider to get accreditation. But many times the accreditation does not translate into the outcomes because nobody is looking at the outcomes. You're only assuring certain basic processes, basic quality infrastructure, but you are not looking at the outcomes. So that's where the whole concept of looking at the outcomes is not just looking at quality accreditation alone. How do you look at outcomes? I mean, that is where I think globally the payment system in terms of the contracting is changing from fee per service to pay for performance. So that's one method of financing, modifying the outcomes. But at the same time, to really monitor the performance with so many variables impacting. I mean, there are individual variables, there are provider variables, and also there are equally important the social variables. I mean, the social determinants also have an influence on the outcomes. So, but in the SACHI's area, I mean, what we did is, let us start just look at the outcomes. So we looked at the two tracer conditions, acute MI, STEMI, ST elevation MI, because it's well standardized. You know exactly what are the outcomes, expected outcomes for a given baseline risk factor. The second thing is the elective procedure, a single mitral valve replacement. What are the outcomes? So outcomes, again, we're looking at what are the clinical outcomes. Then second is a patient-reported outcomes, because what you think is the clinically best outcome in the given situation, from a patient-reported outcome, it may not be the best. I mean, if somebody has a stroke, from a medical point of view, we say that surviving stroke is the best outcome. But from the family perspective, if somebody is debilitated for life, it is not the best outcome. So it's important, I mean, so this is the initial step that has been done in Kerala as well as in UP, looking at what is the STEMI outcome. Then the data was interesting. The mortality figure came as only 1%. It's unimaginable. I mean, some of you know exactly what is the expected mortality with acute MI. Usually it's about 8%. In the best of the care in the world, average mortality is about 8%. So if it is 1%, it initiated another question. Is the data accurate? So what happened is the providers are not providing that information about mortality, because once you say patient died in the claims, you will be subjected to medical audit. Okay. Then some of the patients were actually getting discharged before dying, so it is not accounted in the provider statistics. Some of the patients are dying within the 30 days of discharge or getting readmitted. So it opens up actually the whole system, the sensitizing and whole system. So instead of going directly that I will pay you more money or I will demand performance, we need to understand whether the system has the capacity to actually measure the performance. So we have to start, unlike the Western approach, I mean, what we have been approaching is take provider as a partner for the shared purpose of giving the best outcome, right? So otherwise, if you think a payer is different, provider is different, and we are competing with each other, not trusting each other, in the process, the patient is ignored by both. So if both partner and say that Together, can we give the best outcome? Together, can we make it most efficient in terms of the cost? Cost efficiency should not be, again, at the expense of provider, because I was a provider. I mean, you put a cap on the package by L1 system of CGHS, which is not viable for most of the providers. So when it is not viable for most of the providers, what happens is they don't take the case. That means there is a case selection. So ultimate outcome is you are not actually benefiting the beneficiaries of the providers. So this is, I think, the example of how we can slowly drive the system and sensitize the policymakers, sensitize the insurers, sensitize the regulators, that the insurer is accountable to the beneficiary to get the best outcome and the best quality care. I mean, in the current system, the low value care, that means consultations not required, the diagnostic test not required, procedures not required, account for 40% of expenditure. If you just initiate that process of creating that awareness, I mean, as a business manager, some of you are learning the business manager, because in the process of optimizing your bottom lines, you compromise on these aspects of it. I mean, some of the business managers, we talk the word conversion ratio. I see so many outpatients, how many angiograms you did, whether it's needed or not needed. Please, even if you're a business leader, your ethics is to the medicine. Do no harm, relieve suffering. Once you achieve that, you maximize your return on the capital. You maximize the return to the shareholders. But the primary thing in the business of medicine is medicine purpose. The purpose of not harming and relieving the suffering. So most of you are becoming business managers, because I'm very, very passionate about this, that don't give the top, I mean, I used to say in the care hospitals, we had a corporate governance and the clinical governance. I used to demand the board that why are you looking only at EBITDA? Why are you not looking at the clinical MIS? What are the outcomes with my acute MI? What are the outcomes with my infection, hospital infection? No, none of the board members asked those questions. So as a business manager, please institute these things, that board should ask you what is the clinical outcomes, not just the financial outcomes. If you are able to achieve the balance between the corporate governance and the clinical governance, then we have achieved the actual purpose.
Thank you, Krishna. And it means a lot coming from you, because you effortlessly put one hat down and wear the other. Even during the response, you started with the Sachi's example, but then you kind of culminated in your care experience. So it's very important. To me, the simplest insights are the deepest ones. For example, going from Sandhya's comment to Krishna's comment, what I realize is just making a PMJY scheme and expecting economies of scale and hence improvement is not going to happen. It's not a button you switch on. But the regulator who is in charge of the scheme also needs to be told that you have some power. You can exercise that power, and then that power may have to be exercised gradually over a period of time by co-opting and partnering. But if the regulator or the policymaker who's designed the policy doesn't know that they have these power to drive outcomes, just consolidating pools is not going to do much. So that I think is very important. But I think what you said towards the later part, which is impact on providers as we start doing this, and that simple things that we take for granted, that if I ask for mortality data, I'm going to get mortality data, is not that straightforward. So I want to then go to Dr. Reddy, Dr. Guruva Reddy and Dr. Krishna Reddy. So we have got two Reddys here, and I need to keep them straight in my head. But I'm asking purely now from a provider perspective, and you've seen in your business, you've both built and grown business, and you've seen the payment mix change, right? So out of pocket, or what you call as cash, right? Now turning somewhat more and more towards insurance. Have you seen that places different demands on practice, and the practice also has to evolve in a certain way to keep up with that financing mix change? And if you can share that experience.
Yeah, first of all, I'm very uncomfortable to use the word business in healthcare. That is a fundamental philosophy from which we all should get out, both the business managers, the doctors. When you see the healthcare as a business, the implications are entirely different. No doubt, healthcare has to be done on some principles of business. Otherwise,
Correct.
the corporate hospitals cannot survive. There is no P&Ls. There are no the healthcare providers. But end of the day, as Krishna said, this is the only profession or business where dil se is more important than dimag se. Your heart has to be there. Otherwise, you cannot provide. You take any biggest, most successful corporate hospitals in the world, starting from Mayo Clinic. All these people are thoroughly standing on the fundamental bedrock of ethics and professionalism. And nobody has failed who have done ethical practice. So it's a business manager's a misplaced conception that we have to take care of the balance sheet. There is one balance sheet called emotional balance sheet. And that is very important. I am the standing example for that. Because I can tell publicly, when I took up Sunshine Hospitals 12 years, 15 years back, I don't know what is EBITDA means. I just know how to treat the patient. I want to treat the patient better. So I just plunged into that. And I survived just because of the emotional balance sheet, not because of the financial balance sheet. But no doubt, financial balance sheet is very important. But it should, as Krishna said, that governance should be there. And another thing is, my co-brother Dr. Bhaskar Rao, chairman of KIMS Group, keeps on saying, the insurance is the way out. And it is pathetic that our insurance, as Sanjay was telling, such a dismal numbers. The government has to come out that you can't drive a two-wheeler outside without insurance. You understand, right? You can't drive a car without insurance. Why should you drive your body out without insurance? It is, I can't understand that, why they can't do it. And government has to provide, and it said it has to make insurance mandatory for your social upscale, for your whatever is that you can create incentives. Just like ex-military guys, you got a lot of incentives. Like that, you pay insurance, you will get incentives. Non-insurance, you are no more a citizen of India. You can do that. But another point is, there is no free lunch. And NHS is a classic example of a failure of free lunch. In England, I spent 10 years in England. They got a wonderful system called from cradle to grave. And then people started misusing. They went and started 10 cylinders, kept it inside a house for the COPD. They went and free dental checkup for a glistening white teeth. These sort of misuse. So my feeling is, government has to provide, let us say 60% of the money. The guy has to provide 40%. That might change. But the individual also has a responsibility to keep himself alive, to keep himself healthy. Government has to provide. So that is if you stop 2 cups of tea every day, you can have an insurance per annum. There is no second thought about it. So insurance is nothing out of or unaffordable is no, definitely affordable. And coming to the second point, as Krishna rightly said, the moment insurance guy, as Sanjas also, I deny with her, I disagree with her, the quality cannot be negotiated by insurance guys. There are 100 ways we circumvent the quality. My knee replacement, as an example, let us say I charge 2 lakh rupees for a cash patient. And you want me to pay 60,000, I know how to cut my charges, and I put a second quality implant. I put a second quality of antibiotic, otherwise I cannot survive. So this is optimizing the compromise. So insurance people should be able to understand the actual price ranges, and they should have a common ground with the providers, how much a reasonable or a good quality a clinical scenario costs. These people sit in the ivory towers and then they say, I'll pay you 50,000 to do a knee replacement. It doesn't make any sense. So those sort of things should combine and then provide that. But end of the day, out of pocket, going below the poverty line is definitely not on after so many years of independence in India. We have seen groundbreaking policies changing the whole atmosphere of India. So this also should be the one. I would say by Modi's 3.0 or 4.0, he should make it mandatory that every guy who comes out into society and uses the society free bus, free ride and free electricity should insure himself. That is there, that should be mandatory. Government say, I'll pay something, but you have to pay something. And then that insurance bulk provider will have the might to negotiate the better value and better pricing. If there is one insurance guy comes and says, I'll give you 1,000 knee replacements per annum, give me the price, I'll give you the best price with the same value. So that's what it is. That's my feeling.
We got a glimpse of when you say you manage by heart and then the brain. We got a glimpse of it in 2 minutes. Thank you. I'm going to just ask a follow-up question because you alluded to it, but if you allow me, I will push just a little bit, which is that, let's say, total knee replacement costs 2 lakhs. You can't do it in 50,000. What you are implying is sometimes there is pressure when you move from out of pocket to some institutional. So in retail payment to institutional payment, there is pressure. How do you get out of it? So are there, again, in your experience, have you been able to work with, talk to these payers and say, let's sit down. I mean, Krishna talked about partnership.
Yeah.
Let's sit down and let's do a costing of what a procedure costs given the implants. How would one go about it constructively?
That efforts are going on, but to a little of what you call positive endpoints. We are going and costing and every time with CGHS, EHS, we all sit together and all that stuff. And now the insurance have become a big, how should I put it, mafia. I don't know, I'm sorry, sir. Okay.
I've been in the other rooms who say there's some other mafia.
No, insurance says corporate hospitals are mafia.
Exactly.
So we are all different mafia groups. End of the day, the sufferer is the patient.
Correct.
No, because see, insurance, say 5 insurance companies come together and then say, this is the price, we are giving you that. Take it or leave it. They don't do the costing, but they see the might in their coming together. That is mafia mentality. Mafia mentality is just you make a group and rob the people, whether the corporate or mafia. But corporate mafia cannot come together because we never what you call come across on single point.
Okay.
So we work across the government CGHS scheme because, for example, let us say, I'll tell you a very practical point. One guy with a compound fracture femur comes to my casualty, a young bread earner of the family. He has got an Aragisri, government scheme. Aragisri pays me for a fracture femur 25,000 rupees. The titanium nail I put in this guy is 30,000 rupees. So there is no way I can do justice to this guy. So there is one dilemma, either you go down and put a substandard or ask him to pay from the pocket. I do the second. I'll explain to him very detailed, look my friend, this is this, but government cannot provide this and I cannot do this substandard thing. Otherwise you go and take some other route. But I will do a good thing with this cost. Let me tell you, 8 out of 10 people buy my second argument because they want equality. And especially fractures, first is the best time. You lose that, his patient dies, my patient goes on to the crutches for rest of the life.
Correct.
So which is not on.
Correct.
Yeah.
Fair. I mean, it connects back to what Krishna said earlier, that coverage is not just a theoretical coverage, it should lead to coverage for actual services. And so, I mean, this point has been discussed and debated as to how the package rates are arrived at for different schemes, and, you know, people will tell you that they did an elaborate costing exercise, etc. But I want to come to Mr. Patnaik because I was telling him over lunch that I was part of the Health Insurance Consultative Committee, that's before his time. And one of the things that was proposed to actually resolve this very tricky issue of how much is the cost is to base it on some kind of an evidence-based care pathway, right? So rather than arguing it costs this much or that much, first say, what does it mean to do a total knee replacement? What does the evidence suggest? And this came up in the morning sessions also. There'll be protocols, there'll be guidelines, and the first thing is to arrive at consensus. And maybe that is something that providers and insurers, and by the way, insurers also have medical experts. So I'm not saying talk to the financial person in the insurance company. Is there a possibility, Mr. Patnaik, that either through IRDA or some mediator, let's call it, okay, someone who can bring these parties together, you agree on certain standard treatment guidelines that then form the basis of costing, which can then resolve downstream issues?
Thank you, Professor Saran. Actually, in ISB, I was more like a student. First listening to Madam Sandhya, then Dr. Krishna, Dr. Gurava. Actually, I had a lot of ideas. Coming to Mr. Sandhya, when she tells that, yes, India is a country where 50% people pay out of their pockets. So first job of the regulator is to see that every citizen in the country gets the best of healthcare and well supported by some schemes or the other. So the government, they take care of, as you find, government employees, defense employees, railway employees, Jan Arogya Yojana, and quite a sizable number, almost 12 crore families, 55 crores. So if you take all this together and all, so you find large number of people are covered in some sort of insurance. But that still leaves a lot of people, almost 70, 80 crores people out of insurance. So first, the regulator's job is to have an enabling atmosphere, enabling ecosystem in the country, that yes, I buy an insurance policy. My sum assured is, let us say, 5 lakhs. My payment expenditure is 2 lakhs. And there is an insurance company which will be paying it. It can pay directly to the hospital, or I come out of the hospital, I submit the bills to the insurance company, and then I get my payment. So then that is a concept that my health insurance expenses are covered. I am not paying out of the pocket. So this is a system which is being globally accepted. Nowhere it's a perfect system. As you found Great Britain, they wanted everything to free and it didn't work. Many countries, they have systems which are totally free, but they are also struggling. Many states which are trying to make everything free, they are struggling also, like Arogya, you told, get my point. It costs a lot of money. So the government might be desiring, no, if it is costing 30,000 or 35,000, I should be able to pay it. But some historical rates have been there for 25,000 and the time for revision has not come. So in the process we find isolated instances, I can call it. There may be another instance where the limit may be 25,000, but the expenses may be 15,000. So Gurava Reddy ji will come, okay, don't worry. You come, you take the treatment, best of the treatment, and go home. So these situations will always be like that. So we get many instances like when Jan Arogya Yojana in UP and Kerala, Dr. Krishna Reddy is trying that, okay, it is not just healthcare, but the best outcome of the healthcare. So we are happy to note it. And this ecosystem evolves itself. Maybe 20 years back, we did not have so many hospitals because hospital infrastructure is not an easy thing. It costs quality people, a lot of investment, and investment is not easy to come, you see.
Correct.
You cannot take a bank loan and other things and pay interest and all. You have to have right kind of investors who will have the patience. And many hospitals, they take a lot of time, maybe 5 years, 6 years to break even.
Yeah.
Yes.
It's not easy. So first let us thank all Indians in whichever capacity we are. The providers, they have created a very good ecosystem. And we will still feel, because India is growing, developing and all, people are having the capacity, affordability, they need healthcare. So this infrastructure is only going to increase and increase. Earlier medical colleges, we were having one in a state. Today we are finding one in districts.
Correct.
So as you told rightly that how it evolves, because Hyderabad, when I see, a few days back I was in a hospital to visit one of my colleagues who was there in the hospital. I found a lot of patients from outside. So the colleague was with me who had taken me to the hospital. I asked him, there's so many patients. They said patients come from all over the country. Giving that example, that means the health ecosystem in Hyderabad has evolved itself to provide some sort of quality health care. And at the same time I asked, they said it is also very affordable.
Value for money.
Value for money.
Correct.
So slowly and slowly, maybe another 10 years down the line, we may find other state capitals, other maybe district headquarters where the hospitals are also growing. They may be also evolving in this manner.
Sure.
So this is all function of the ecosystem, market ecosystem. The paying capacity of the people, the good relationship of the payer and provider, or let me put it, the insurance company and the hospitals, and the affordability of the people to pay the premiums. And the job of the regulator is to have constant stakeholder engagements and discussions.
Absolutely.
So companies are also evolving in their products.
Correct.
Suppose I can have a 2 lakhs of basic insurance policy because I cannot pay more. I can have a top up of 5 lakhs if it is needed, if it is triggered and all these things.
Correct. Correct.
Then there are co-pay methodologies, like a lot of young people, I told you in the
Yes.
afternoon.
Yes.
One of the incentives or one of the desire that I want to come here is I'll be meeting a lot of young people who are the future of the country. Because they will be driving the future economic scenario and whatever, if it is healthcare system and everything, because they will be the business leaders, they will be, many of them will be engaged as customers also. Like I was telling you, suppose a young person is there. Normally you find a young person unless he becomes 40 or 45, he or she doesn't take insurance. But insurance can be needed at any point of time. But when he takes an insurance, he or she takes an insurance and gets his parents into it, the premium gets substantially reduced. So these are the ways and means. So we have observed. So when more and more young people will be there in insurance also, the premiums will tend to get reduced while providing coverage to all the elderly people also.
Got it. Got it.
Thank you.
Fair. I mean, we heard from two people. So those who are not insured here and call themselves young.
Let us ask how many people are insured.
I guess this is
And
yeah. I
health
mean,
health insured.
yeah. Some of them may not be.
Right, okay. That's
It's
good.
through employers. Most likely they're in the
okay,
formal
because most of
sector.
whatever is that.
Different demographic, but good. Most people are insured.
So the ecosystem, suppose the number of people who are insured commercially, the number of people will be around say 10 crores.
Yeah.
So maybe 10 years down the line, it will be 30 crores and it will substantially
Fair.
reduce the premium and also.
Fair. I mean, one thing, because you talked about ecosystem evolving over time and tying it back to the out-of-pocket expenditure, because new evidence is suggesting that this out-of-pocket expenditure is not only hospitalization expenditure, a lot of it is outpatient expenditure. Okay? So, I mean, many discussions this has come up. We have some insurance products that cover outpatient expenditure, but they're not very good. Any thoughts from IRDA? How can we move in that direction?
Evolving scenario, and many of the insurers, they also, because if you'll be surprised to know that they've got tie-up with many of the Ayushman Bharat hospitals. So we call it like preventive, promotive, curative healthcare. So, and it's a win-win situation for both the insurance company and the patient also,
Got it.
which could have needed hospitalization, maybe a surgery and all these things.
Got it.
At the very early stage, it is preventive. And
Again, the mindset of the people should change. Of course, it's an evolving system. I'm very happy. I'm always an optimistic, I'll say glass is half full rather than half empty. We have come a long way, provider-wise, the insurance-wise, the quality of services, the outcomes. We are no doubt evolved a long time. But somehow the patients have stayed back. They still think that complication is the complication provided by you.
right.
They don't understand the complication is a part of a treatment. Negligence is different from complication is different.
Fair.
And second thing is whatever the ecosystem, I'll tell you as an example, the people who are going down below the poverty line don't need to, because 80% of these people are insured or provided by the government schemes. But they don't use the government scheme.
Right.
They want the best in the city. They like to sell the jewelry and go to that guy. Why don't you go to the government hospital and get the treatment done?
Fair
And
enough,
again,
yeah.
50% of the treatments they are getting through corporate hospitals can be done as effectively by a government hospital doctor, except a very niche areas.
Fair.
So that is the mindset has to change.
I understand.
Yeah.
I mean,
I
I'll
agree
just
with
be fair
Gaurav
to
ji.
those people because they don't have a podium here. So
Yeah,
it's
that's
hard
what I
to,
say. Yeah, I
it's
know.
hard to comment on,
No, but what I'm saying is,
Yeah, fair.
we have to educate them.
I agree.
Yeah.
I agree. I'm sure
Yeah.
some people will raise their hands to say we can educate, but I'm guilty of not having a representative from that group here who could speak for themselves. So I'll take that blame. But let me actually go and circle back to Sandhya. A lot of discussion on insurance, Sandhya, right? From out of pocket, we've moved to insurance. But there are also other payment models, right? I mean, there is a capitation based model. Could you talk a little bit about those? I mean, we may be far away. Again, the ecosystem will evolve over many years. But maybe some countries have those capitation models, and what's the evidence on their effectiveness to deliver value and outcomes?
Yeah, actually, Sarang, this connects so well to the conversation that was just happening in the last minute or two. And we may not even be that far away in terms of that this is already part of the government of India's vision. Oh, you can't hear me?
No, go ahead, you're good. Go ahead.
Yeah, okay. So this is already part of the government of India's vision. So when the Health and Wellness Center program was launched, it was envisioned to have a capitation element to it, but for whatever reason, all that has not been implemented. We've been talking about hospitalization costs and perhaps needless hospitalization. So capitation is a very effective way of bringing the focus to preventive care. As we all know, much of healthcare in India is curative. We go to a doctor when we are sick. We never go to a doctor to basically just get regular screening done to assess whether we are on the verge of sickness or not. That's as a citizen we don't go, nor is the system geared to really come to us to screen us on a regular basis, as it does in a lot of other countries, to really look at what is the status of population health. So capitation is really a system that enables that, because then the payer, typically the government, is paying the provider X amount for a certain period of time, let's say per month, for every citizen that is registered with that doctor or with that facility. No more, no less. So if that person, let's say me, if I get more sick and the facility is incurring more expense because I've gotten more sick and I need more diagnostics, I need more surgeries, too bad. The provider will have to pay out of his or her pocket, because according to capitation, only that X amount is to be paid. So that is an incentive to actually focus very strongly on preventive mechanisms so that my health is managed. So that's the beauty of capitation, and many countries have moved to capitation systems, and not just recently. This has been happening for the last at least 20 years, right? And in the interest of time, because I know we're running out of time in the session, let me give you two very quick examples. Now, Brazil is a country where their primary care system is spoken of very highly, and they introduced capitation around, I think, 2000. Little before, little after. And one of the outcomes of that has been that hospitalization rates have reduced considerably over a period of, I think, 15 years, from 2000 to 2015-16. There was a 45% reduction in hospitalization relating to primary care conditions, asthma, hypertension, etc. 45% reduction is not trivial. Also, the percentage of population that was covered by primary care services, again in about a 15-17 year time period, increased from 22% to 62%. And the other benefit that the reform of capitation introduced was that there was a lot of focus on improving and augmenting primary care infrastructure at the municipality level. One other quick example is Turkey, again, because Turkey has had very successful reforms, and Turkey's reforms also happened around 2000. So between 2000 and 2020, saw a huge out-of-pocket reduction as a result of. So I should point out that these shifts are not just because of one intervention.
Sure,
obviously,
sure.
they're a result of multiple interventions.
Correct.
But all of these played a role. The interesting thing in Turkey was the convergence that was visible across less developed and more developed regions when capitation after capitation was introduced. I won't say that caused it. Two quick examples on that the difference in ANC coverage across regions was 30% in the early 2000s, and by 2018 this difference had reduced to 1%. Across regions. The last example I'll give is on immunization. Again, the difference in immunization across better and less developed regions was 28%, which reduced to 10%. So the point is that, a lot of the preventive promotive stuff that typically our systems don't focus on, although they are the bedrock of a health system, something like capitation brings those into the fold.
Got it. Got it. So you're looking at a provider who is paid a certain fee per capita, and they are bearing now the risk of expenditure. Their income is constant.
Right.
They are bearing this risk, and so they will take actions to reduce the risk, to reduce the expenditure. That's the hope.
Can I just put in a caveat there?
Yeah.
America, the recent last decade or more than 10 years, they came up with a bundled payment. And that means, let us say, in the previous days, a knee replacement, surgeon can charge $10,000, hospital will charge another $20,000. Now, on the national standing of the hospitals, they say for one knee replacement, I'll give you bundle payment of $10,000. And that made a dramatic difference
Fair.
between the excessive costing of the
Correct.
insurance people.
Correct.
So
Correct.
that is again a way forward.
Correct,
That's
and
what
that I think
Sanjay was telling.
correct, and I think
Yeah.
capitation is even 2-3 steps beyond that,
Beyond that.
where rather than even focusing
Correct.
on one episode,
Exactly.
you're saying the entire health will
yeah.
be covered.
Yeah.
Fair, but I think that these are ideas, right? And so Krishna, again to come to you, because you've seen the international experience, right, and then also Indian. What's the sort of tip of the arrow, if you will? Where can we start? If in India someone said, let's do capitation, and I know there have been pockets of experimentation. What's the right starting point? Is it a district level? Is it a city level? Is it state level? How would one go about it?
Yeah. At least, we are attempting a population health management concept as a pilot in 200,000 population, a closed population. Again, assuming the same thing, a capitation.
Yes.
Per capita 600 rupees or something. Within that capita, how to improve the outcomes. So that's how, this is with the RTC we are piloting, the Road Transport Corporation, because they have stable population, they're dependent families, and we know the baseline, their health profile, what is their expenditure today per capita, which RTC is incurring, both providing themselves and also purchasing from empaneled hospitals. Just like the government, right? Government also is providing themselves and purchasing from empaneled hospitals. So if the focus is on the same thing, right from health promotion, what is the impact on the expenditure as well as the outcomes? Disease prevention and early screening, what is the impact of it? What is the improvement in productivity? And what is the reduction in hospitalization? And today, if suppose they are not accessible to innovative molecules for a cancer, advanced cancer requires immunotherapy and it is not affordable. But if you do at a population level by conserving expenditure through promotion, prevention and early detection, we don't deny the innovative molecule to a patient with cancer. So this is exactly the capitation. If I look at PMJ as well, the capitation is 600 rupees per person or 1600 rupees per family or whatever it is. So one of the advice, we are experimenting with Sachis and PMJ as well, is why don't we look at the beneficiary's health profile? The health and wellness clinics are designed for that. But unfortunately, the NHM and NHA don't talk to each other. So the whole objective of that continuity of care with outpatient care and inpatient care, that is not happening. If it happens, that is as a Ministry of Health, as a finance ministry, will question with this per capita cost which you are spending, what is the outcome? So if I say it's not just the insurer asking the provider, even Ministry of Finance can ask Ministry of Health, we are spending per capita this much, what is your outcome? If it starts demanding that, what is the outcome, then the NHM and NHA will talk to each other. Otherwise, they don't talk.
Got it.
Okay, so that's, similarly, we are trying to pilot district pilots as a part of WHO CRO Primary Healthcare Forum. 5 regions of the country and 11 countries, 1 district. Similar concept. You look at as an overall health system in the district, both private as well as public. what public is providing, what private is providing, and then as an overall system, how it can optimize with primary health care as the anchor. Yeah, these are some of the pilots which may be appropriate. I mean, I think when we look at the international Western approach in terms of purely linking it, financing, the administrative cost of that financing model, especially in the US, has gone up to 25 to 30%. And now they're shifting to the Affordable Care Act, I mean, the ACOs and other things. The cost is further increasing because the amount of data that you have to monitor in terms of the outcomes and linking the payments to the outcomes. So maybe I think India, based on the learnings from the West, I mean, what really worked, what did not work, we may have to innovate in a different fashion. And most of these models, one more thing I just have, I mean, we take out the patient out of this.
Yeah.
So if you really ask the patient, like what Gurva said, I mean, you have a government hospital, free services, they don't get. So we don't account for whether the patients trust this hospital, the empaneled hospital or the free hospital. So we have to ask the patients actually how they want the provision. They're willing to pay something. They're not saying that we're not willing to pay. But they want that freedom of choice and the trust in a system. Okay. So yeah, this is a little more complex, but I think it can be piloted. I think should not be done at a national policy level. We should first evaluate what are the key variables which are playing out, including the patient factors, and then how the system should respond to it.
Fair. I mean, this is very fascinating, and I have to ask a follow-up question because it's not intuitive to me. You said Road Transport Corporation. I would have always thought of a geographic unit as a pilot. Could you talk about how you landed on RTC as a unit of analysis or unit of pilot?
Yeah,
because there are practicalities there, so I would love to know more about that.
Because one of the troubling question about the primary health care, in the villages, it is easy to organize the primary health care. It is geography and population is closed and everybody knows. But in the urban system, if you apply the same logic of geography, I don't talk to my neighbor apartment. So that community does not exist in terms of the geography. In urban setting, the community is the workers, your colleagues. See, Microsoft or Google or Kim's Hospital. So you have 1,000 families or 2,000 families, 5,000 families.
ISB.
Yeah.
ISB has 100.
So if you take that as a community and design your health delivery system for that community. In fact, we wanted to pilot in, say, Microsoft Office. Same thing. I mean, you impart health literacy to entire staff, do the health profiling, and then demonstrate to the HR of Microsoft that by investing in this prevention and early detection, your hospital bill actually will come down.
Got it. Very, very fascinating. Last question in the interest of time before I go to the audience. Dr. Gurva Reddy, I'll come to you. As these discussions happen about capitation models and moving from curative to preventive, promotive, a natural question is those who have cut their teeth in curative care, right, or in procedures. Is there a discussion internally in the organization saying, how do we get ourselves ready for that world where we may have to step out of hospitals? How does one, because there's an organizational change issue there as well.
It's already happening in the sense, in the olden days, there is a joke. If you put an emphasis on the preventive medicine, who will come to you for the curative medicine? But preventive medicine will enlarge your footprint as a healthcare provider. And the people also realize, okay, these guys are talking about the holistic management of the health. In case if I fall sick, he is the man to go. So the trust factor will be tremendously increased if we, the providers, go out into the society and catch the population and teach them preventive and teach them lifestyle medicine, teach them how to take care of your diabetes without coming to hospital, how to take care of your asthma. These sort of things are already in place, but I would feel that much more to be done. A lot of camps are being done from the corporate side, and we feel that that is the way forward, and that will enlarge the footprint, and it will be good for the balance sheets also. It is not the other way around.
Sure.
But as I said, a corporate hospital or a business manager, because all of these going to be running the hospitals tomorrow, should be seeing a patient as a person, not as an entity. Yeah.
Thank you. That's a very positive note. I'll pause on that and then open it up for audience. They may have questions. I guess we've got 12 minutes. We can run 2-3 minutes over. Someone can moderate this. Okay.
Yeah. Hello. So good afternoon. I'm Dr. Ramesh. I'm a radiologist, senior consultant based at Hyderabad. So I just wanted to ask a question to Dr. Gurav sir. You said that don't look at hospitals as a business model, right? So now with a lot of hospitals and diagnostic centers going IPO, I think a lot of people put their money only where there's profit, right, sir? So how can we bridge that gap between, seeing it as a business and seeing it as a, do we need to have more people from as doctors to head institutes rather than having people coming from outside to head hospitals?
Yeah, again,
Is
sir,
that,
a good hospital is a good hospital both for the patient and for the financial guy. There is no second thought about it.
Correct.
Because the financial guys also see, in addition to your balance sheet, your professionalism, your ethics, and your value in the society. I know a lot of people, the private guys, came and saw the EBITDA only, but held back because the hospital doesn't have a good clinical governance, a good outcomes. As Krishna, I'm sure you know some hospitals in Hyderabad itself. And some people have come and put the money on the hospitals who are struggling, but still got the professional ethics. So the IPOs don't take that they are here to suck the blood from the patient and from the hospital.
So
they also know, but what I'm saying is, you're right, their emphasis is on the balance sheet, but no hospital can, or I will rephrase this way, no hospital need to worry about the IPO involvement and my inability or my compromise to do good to the patient. I don't think it will happen at all. There is slight somewhere discrepancy. For example, let us say, I want to put a 10 lakh money on a patient comfort delight by expanding a beautiful launch, making like airport launch. The IPO guy might say, no boy, it's not a return for investment, let us make it a small room. So that sort of thing. But the majority on a macro level, IPOs won't have any ground, or the hospital need not worry that the IPO money is making me much more commercial than humane.
So one more thing is that would you prefer?
One question, if you don't mind,
Okay.
because there's
Yeah,
too
sure.
many hands I see.
Thank
I
you.
apologize.
Okay.
I think we need to give chance to everyone.
The lady.
There is one right in the front here.
Yeah,
He is asking, yeah, he's there. He's there.
We go to the back benches first.
Later on, yeah. 30-second question. For India as a healthcare model, capitalistic country or a socialistic country, what do you think?
100% capitalistic.
Mr. Patnaik.
The no socialist country has proved
Yeah.
that they
And
got a
Sandhya,
good
of
healthcare.
course. Yeah.
This is not a 30-second answer. It's a 30-second question.
No, I will just see,
So
at
this
the
is
system
to-
level, everything is golden mean. So ultimately, it is the mean. It is not neither capitalistic nor socialistic. It is always a mean. So every time the pendulum settles at the mean.
Because I'd like to respond. You see, in the primary healthcare and the secondary healthcare, a lot of investments have been made by all governments, central government and state governments. So that ultimately health ecosystem, early diagnosis of critical diseases also. So it will be always be a mix. It will always, in most of the countries, in US also, you see, you cannot say it fully capitalist and all.
We had a
So they'll be
comment in the
different.
morning that said India disappoints both pessimists and optimists. So India disappoints both capitalists and socialists. Okay, let's put it that way. There's a
I
question
would
in
say,
the back.
can I just say, I think it should be patient-centric and not in terms of capitalist
Fair.
or socialist.
Fair, Sandhya. Fair.
So this is to Dr. Gurva Reddy, sir. Sir, I am Dr. Shruti from Pfizer. So, sir, we are into rare disease portfolio as well. So I just want to understand. So government has granted 50 lakhs for the as a rare disease policy. So what are the gaps you find to reach that 50 lakhs to the patient who are suffering from the rare disease and the patients who are included in this rare disease policy?
I didn't get that. 50 lakhs?
50 lakhs. The government
No,
has
the
granted.
question is related to the rare disease population. Because most of the public focus is on the common diseases, the mother and child and tuberculosis and HIV. But the rare disease, each disease by itself is a small population.
Which disease?
Rare
disease, okay.
Rare genetic
Rarest of the
Okay.
rare disease.
But globally, I mean, when you pull up all the rare diseases, about 7,000 rare diseases, it is 300 million people. In fact, we are starting an alliance for the rare disease. One of the approach, what you mentioned, because some of these treatment cost 50 lakhs, 1 crore, 3 crores, they're highly expensive. But just like the Global Fund, just like the Gavi, the concept of pooling the resources. That means the public money, because the taxpayer may not agree for somebody to be paid 2 crores, 3 crores for a rare disease, right? So naturally, there is a taxpayer money, there is a limit. And there is a lot of philanthropic money which can contribute to that. Then the industry also is coming and saying that we may provide these technology at a cost price. We are not putting a value to the patent.
Yeah, there are some.
So this is concept, I mean, the Global Fund is working in the same concept.
Yeah.
Right? It's the government money, there is a private bankers money, and there is a industry money and philanthropist money.
Can I just put a small spin on that? Slightly it's politically incorrect. In England, there is a debate going on. In England, NHS expenditure, 60% of the expenditure goes to octogenarians who are not productive to the community. The fracture neck femurs and all these guys. Am I right? Rahul is here. And so there is a small section of the people coming and arguing, why should I pay to this guy who is going to die tomorrow? There is no national productivity at all. So why should the whole pool of money, 60% of the money, goes to that? But that on the face of it, it looks very, very crude and politically incorrect. But if you see, go in depth of it, there is some truth in that, but there is no answer for that.
Manoj here from CCMB. I'm a scientist with CCMB. First question to Dr. Reddy, who is from KIMS, is that I agree totally with you about that preventive healthcare and other things, because everybody puts a conference and meeting on healthcare. Actually, most of the time since morning, we have been focusing on sick care. People after a health breakdown come to a hospital. Healthcare should include preventive and other things which you mentioned. So that awareness we all have to inculcate, and how we can avoid or manage our disease or reduce the patient to the hospital. Because once a person reaches to the hospital, now I'll move to another Dr. Reddy from the Alliance about the AMR, because that's another serious issue. When we go to hospital, we bring other guests from the hospital, nosocomial infections. For that, what government is doing, and also about your effort with RTC, because in India we lack organized information for analysis and for further planning. So since RTC is a group of people, let us say drivers, conductors, they are exposed to the same environment, chemicals, pollution, situations, work atmosphere, everything. So there's a new field where we are trying to work. It's known as molecular exposomics. People who are exposed to particular things have particular diseases. So are you making a cohort of those entire one group, because a golden opportunity for us to do? So that's all I wanted to ask and convey. If you could.
Yeah, the question is, I mean, basically, it is a whole of society and whole of governance approach to the health management. I mean, since you have covered 3-4 things in terms of the impact of the environment, the social factors, and the health. So that is one element of it. That is one area that we keep discussing when we say health financing of 1% of GDP. It does not take into account the amount that is spent on other elements which have a bearing on health. Whether it's Swachh Bharat or Ujjwala scheme or water to the every house. So that is one element of health promotion and disease prevention. The second comment he mentioned again, antimicrobial resistance. Most of the focus is on indiscriminate use of antibiotics in the hospitals. But the key determinant, it is not just that single factor. In fact, the amount of antibiotics being used in the animals, amount of antibiotics that are drained into the ordinary waters, right? So what is happening there? I mean, what are the mutations that are happening in those areas? So one of the solutions should be, again, systems approach in terms of why the doctors use antibiotics. Because there is no rapid test to tell you, even like CCMB, like organization, there is a challenge. Can you tell me with a single test, is it a bacterial infection, is it a viral infection at the point of care? If you can provide that technology, innovative technology, that I can tell somebody comes to me with a fever, I can say whether it's bacterial or viral. If it is viral, I don't use antibiotics. As simple as that. So the system has to think why people use antibiotics. If I don't use, patient will buy from the pharmacy. So there has to be guidelines. So I think it is not that simple to say that we can prevent antimicrobial unless we look at totality, not just by focusing only on overuse of antibiotics by the clinicians. That is one aspect of it, but that is not the only aspect of it.
Krishna, can I tie it, because the question was very broad, but I want to tie it to this discussion, which is in terms of financing, if we were to track hospital-acquired infections, if we were to track prevalence of AMR in patients that get discharged, would there be a way by which, in small part, I could use again the financing lever?
Yes.
And then say, let hospitals figure out the best way to reduce these so that they get rewarded accordingly?
Yeah, so one of the lever is the accreditation. Because once you have an accreditation, you have a mandate to actually report what is your hospital-acquired infections and other things. The second is when you, for example, the ACO model, if there is a re-hospitalization within 30 days, you are not paid again.
Correct.
But in the current system of fee-for-service, I produce a complication, I get paid.
Correct.
That's the the irony of the thing is, so that means I'm not constrained to produce a complication.
Correct.
So by linking to this, that means if I'm discharging based on the average length of stay, I want to reduce it to 3, I'm discharging prematurely and they come back for readmission, the penalty should not be on the payer.
Correct.
It should be on the provider.
Fair. Okay, we can take one more question.
Yeah. Hi. I'm one of those educated Indians who took a health insurance policy when I'm in 20s, and currently I'm a master's student. So my institute also pays for a health insurance. I cannot leave my original policy because if I leave it, the waiting policy will elapse and I would have to wait again 2 to 3 years for getting all the benefits. So technically I'm doubly insured, and this may be true for many of the formal employees who have insurance on their own and insurance from the company. Has there been any attempt to look at what is this and how do we solve this? Because we are just wasting a lot of premiums through the company and through personal.
The law states that you can only claim from one insurance policy. Suppose if that limit is exhausted, you can trigger the insurance limits on the other policy. So it happens with most of the people. So that means some companies, they only provide for the individual. But suppose I desire for my family, I take it along with the family and I also include myself there also. So it happens, but the numbers will be very limited. It may be 1-2% of the total insured population. I'm also part of it like that, get my point. So it happens, but okay, the more the insurance it is better, you feel more secure because sometimes, because yes, what is the limit of insurance one should have? It depends on individual capacity because your treatment can range from as low as 50,000 to as high as 50 lakhs, you get, or somewhere in averaging between 5 to 10 lakhs. So that should be an ideal which an individual can decide. And they have basic, then they have top up. Then if they have 2-3 insurance policy, yes, this I trigger it immediately. And if that is exhausted, then I trigger the next one. So this happens like that.
Okay. Thank you everyone for being participative. In the interest of time, we'll have to stop the discussion here, and I think the discussion will continue. The questions raised during the discussion were thorny. I don't think we resolved all of them, but hopefully we'll discuss socialism, capitalism and other things during the break. Thank you. Thank you to all my panelists here. Sandhya, thank you so much. Thank you.